Good evening, ladies and gentlemen. Welcome to another edition of the Pulmonics Lecture Series. We have three special guests this evening. Dr. Douglas E. Wood, MD, is a thoracic surgeon and the Henry N. Harkins Professor and Chair, Department of Surgery at the University of Washington. He was the principal investigator of the National Emphysema Treatment Trials, the first trials of lung volume reduction surgery. And he is they run the first and largest program in the country for LVRS. He is also intimately involved in the clinical trials of endobronchial valves since they were first introduced. Welcome, Dr. Wood.
Thank you, Noah.
Our next contestant, Diane Lockhart, is the nurse coordinator and case manager of the emphysema surgery program, also at the University of Washington, AKA Dr. Wood's right-hand woman. They have been working together since 1998. Our next special guest is Angie Danaher. Angie Danaher is a patient of Dr. Wood. She underwent endobronchial valve procedure on June 1st. She loves gardening. She loves the outdoors. And we found out today she runs her own Sawzall. Welcome, Angie.
Hi.
Dr. Wood,
Right,
take it away.
Thank you, Noah. I'm going to get my slides going here. Yeah, welcome everyone. It's great to have a good crowd learning more about bronchoscopic lung volume reduction, or the use of the Zephyr Endobronchial Valve. Thanks for the great introduction, Noah. I appreciate it. And so we're going to be talking about bronchoscopic lung volume reduction and really how this is provided a new option for patients compared to the medical therapies that they've been on, as well as less invasive than some of the surgical therapies that I am going to address. I'm a surgeon. I've been involved in part of the development of and research of surgical therapies and endoscopic therapies for emphysema for a majority of my career. So having endoscopic treatments or bronchoscopic valves that we're going to be talking about is a great newer addition to the modalities that we have for taking care of patients that have symptoms of severe emphysema. So this is just a roadmap of what we're going to go through in the next half hour, 45 minutes. We're going to talk some about what emphysema is, what the treatment options are for it, get into more detail about what is bronchoscopic lung volume reduction, and I'll give you a video about that and give you some details. And then we'll talk about the results of bronchoscopic lung volume reduction, BLVR, so that you know a little what the outcomes are for people, and some information about how to know if you're a potential candidate and what it's like to go through it. And we're really fortunate to have our patient, Ms. Angie Danaher, to talk with you about what it's like as a patient, what it's like to go through some of this evaluation, the procedure, and what to expect in terms of the recovery and what to expect in terms of potential improvements in quality of life after the procedure. So I'm going to talk a little bit about normal lung function because that helps to set the stage for what happens when you have emphysema. And most of us have at least a rudimentary view of what happens when we're breathing. We know we pull air in and out, and our diaphragm down at the bottom of the lung tightens up. That helps pull air into our lungs. Our rib cage expands, the diaphragm pulls down, and that's how we get air in. And then the diaphragm relaxes, the rib cage tightens again, and that's how we breathe out. And we do it all day, every day. We don't even, none of us think about it until you have emphysema. And then what I hear from my patients with emphysema, they think about it every day. And that's what's bad, because we don't want to have to think about breathing. And this is what happens when you have emphysema. A healthy lung, the lung tissue is very elastic. And so, when you inflate it, it has some recoil. And when you stop inflating it, it will deflate. And the breathing is easy. We remember that from before we had emphysema, and the lung expands and contracts normally. What happens with emphysema is it destroys some of the elastic tissue within the lung. And the lungs get kind of bigger and bigger. There's air trapping in the lungs. They get overinflated. And that kind of enlarges the lungs, makes them tight within the chest cavity, pushes down on the diaphragm, and it makes it hard to breathe. And the picture on your left shows kind of the normal contour of the diaphragm and the chest and what the lungs look like. And this is what happens when the elastic tissue in the lung gets destroyed and they get too big. It pushes the diaphragm down, and it expands the chest cavity, and the lungs are tight within the chest cavity. Diane, who's been working with me for over 20 years, is tired of hearing me give analogies to this to patients. This is the analogy that I give to patients, that it's like a balloon, and we know what it's like to inflate a balloon normally, where yes, it's full and it has some tension, but it's not about to pop, it's not over distended. But then when we were kids anyway, we also overinflated those balloons, maybe enough to make them pop. And you can imagine, when you've got that level of tension on the balloon, that it's just harder to move air in and out if you think of that being in your chest. And this is kind of maybe more of a technical slide about that, but this loss of elastic tissue within the lung results in some collapse of the small airways, air trapping within the lung, expansion of the rib cage and flattening of the diaphragm, and ultimately inefficiency of the respiratory muscles. And this increases the work of breathing. And when it's hard to breathe, that's what produces what doctors call dyspnea, but is a better term, shortness of breath. That's what it feels like to just have trouble getting air. And the disease progression as we get COPD and the subset of COPD that is emphysema is the lungs get hyperinflated, you get short of breath. That can result in decreased activity. Then that follows decreased exercise capacity, and it becomes a spiral downhill of further decrease in activity, more shortness of breath, deconditioning, then getting out of shape, and ultimately becoming life-threatening, where exacerbations or just debilitation of being weakened by lack of exercise and inability to keep oxygen levels up can ultimately be fatal. And so this is the progression of people that have the unfortunate aspect of having COPD and emphysema. So what can we do about it? And that's why all of you are here. What other treatments? Most of you know many of them. Starting with the non-invasive things is the regular medical management. And in fact, that is a core tenet to caring for individuals with emphysema. There's the inhalers and oxygen therapy and sometimes steroids and management of exacerbations. That's all the medical management that your primary care or pulmonary physician does and is really critically important. Then there's the aspect of care that involves pulmonary rehabilitation. So doing a structured program of exercise and educated techniques of managing emphysema, of improving exercise. Pulmonary rehabilitation, I advise people, it doesn't really change your lung function, but it changes how effectively you can use that lung function, like other exercise. It means that you can do more with the same lung function, but is a really important part of avoiding deconditioning and not going further down that spiral that I showed a few minutes ago. Then we move to invasive procedures, and some of you may know about lung volume reduction surgery. Yeah, this is a relatively new surgery developed in the early 1990s and led to a study that I'll point out in a minute that really removes part of the lung. You know, we talked about the lungs being overinflated, them being too big for the chest. Lung volume reduction surgery actually removes part of the lung to make the lungs work better. It seems paradoxical, like it shouldn't work. But in fact, if part of the lung has almost no function and we can remove it and make the lungs smaller and fit within the chest better, it can help the respiratory muscles to work more effectively and can really improve pulmonary function, lung function, and quality of life. And then actually a procedure that's older than lung volume reduction surgery is lung transplantation. So really trading in the old lungs for new lungs. Lung transplantation is really for people with end-stage disease, but is also a very effective and important therapy that can be life-saving for people not just with emphysema, but with cystic fibrosis or pulmonary fibrosis or other conditions of lung failure. As I said, you know, lung transplantation was started in the 1980s. We started our lung transplant program at the University of Washington here in Seattle in 1992. And I just put this up because last year in 2019, we passed a milestone of 1,000 lung transplants here at the University of Washington. Lung volume reduction surgery, I said it's newer than lung transplantation, and that's kind of true. But there was an old version of lung volume reduction surgery that was tried by a doctor by the name of Otto Brantigan back in the 1950s with what then was some pretty rudimentary surgical techniques. And because of that, it was also not very successful. And it was tried, fell out of favor, and really was not tried again for about 40 years. And the principle of lung volume reduction surgery is what I described a few minutes ago, is if people at the top of their lungs have, parts of their lung that really aren't working, we can actually remove that part and not lose any meaningful lung function, but make the lung overall smaller so that it improves that elastic recoil and returns it back towards some of the normal function. It doesn't make the lungs normal. The lungs still have emphysema, but it can really make a difference in shortness of breath, the quality of life, and exercise capacity for many people. And these are some of the studies that we do to evaluate it. This is a scan where we look at where the blood flow is in the lung. We can see that there's no blood flow up here in the upper part of the lung, a lot of blood flow down here in the lower part of the lung. That helps us know that we can remove this upper part of the lung and make more room for this lower part to work better. This clinical trial, the National Emphysema Treatment Trial, this was a really important a clinical trial, meaning a trial to evaluate a new surgical procedure that actually randomized people to having surgery or not having surgery, and to see, did the surgery make a meaningful difference for people? And this was done at 17 centers around the United States, a very large, meaningful trial that was then published in the New England Journal of Medicine 17 years ago, and showed a substantial benefit for properly selected patients. And I emphasize properly selected. This doesn't work for everybody with emphysema, but for properly selected patients, that they could have significant improvements. And many of you might have seen some of the press about this. There was a lot of press at the time that the procedure was a breakthrough for emphysema. It's now more mainstream, although still not as widely available as some of us think that it should be in the United States. But lung volume reduction surgery, by reducing the volume of lung did show important improvements in quality of life and exercise capacity, lung function, and even in some patients, an improvement in survival. So a decrease in mortality of emphysema. So that's all great. If we could stop just at this upper part of the slide, we'd all be sold. That sounds terrific. The negative is that it's a big surgery. And so a big surgery in people that have fragile lungs has the potential of surgical complications and a time of recovery that can be prolonged. I mentioned that it's not feasible for everyone. In fact, as a majority of emphysema patients would not be good candidates for lung volume reduction surgery. So it can't take care of everyone. It's expensive because it's a big surgery and time in the hospital. And I think an important point, it's irreversible. Once we take that part of the lung out, we can't put it back in. Once we've done that, that procedure is done. One can still have a lung transplant after lung volume reduction surgery, but you can't put that piece of lung back. So that's the background that I think is really useful for understanding bronchoscopic lung volume reduction. And that's really what we're here to talk about. And we're here to talk about the Zephyr valve. And the Zephyr Endobronchial Valve is now approved by the FDA for people with severe emphysema. And just to kind of go through what it is, what it does, it is a very small device that goes into the airways. I'm going to show you a video in a minute so you can see what that looks like. That by plugging part of the airways to the lung can work on reducing the size of that lung, can purposefully collapse a lobe of the lung to try to accomplish the similar effects that we talked about with lung volume reduction surgery, but without surgery. There's really important selection criteria for patients. We're going to be talking about that. And with any new device like this valve, like the surgery that I was talking about, it's important to recognize that there's clinical trials. There's been research that has gone into evaluating the safety. So can these be placed and is it safe? As well as efficacy or effectiveness. It's one thing if it's safe, but does it also work? And then if it works, is it also approved and put into guidelines? And do people accept that it is a meaningful therapy? And one of the positives about an aspect like placing a valve like this is that it's reversible, it's removable. And I have had to remove valves in patients either where they didn't have benefit and we thought it was better to just take the valves out, or in individuals where one of the valves that we had placed wasn't quite right and it was better to either take that one out and replace a new one that was bigger or in a slightly different position. So we can tweak and or change this procedure, unlike surgery, which is irreversible. So I showed this graph before of moving from left to right of non-invasive to invasive, from medical management to very invasive management of getting new lungs. And the Zephyr Endobronchial Valve really fits in the middle. The Zephyr Endobronchial Valve is minimally invasive. It's more invasive than medical management or rehabilitation, but it's far less invasive than lung volume reduction surgery or lung transplant. So it's in this kind of sweet spot in between the best medical therapy that we can do and the surgical therapies that we can do that are important and are effective and are options for individuals, but aren't options for everyone, or might be options, but maybe things that some of you don't want to do and would rather have a less invasive approach. So this video that you see in your lower right-hand corner shows how a valve has a kind of one-way feature that allows air to come out. And I'm going to play a video now with sound that will show you a little of how the valve is placed and how it works.
The Zephyr Endobronchial Valve is a proven, minimally invasive treatment designed to improve breathing, activity, and quality of life for emphysema patients who are breathless despite maximum medical therapy. The Zephyr Valve procedure is performed under general anesthesia or conscious sedation, where a standard bronchoscope and flexible delivery catheter are used to guide the valves into the target lobe and desired airway. Multiple valves are implanted to ensure complete occlusion of all airways leading to the target lobe of the lung. Valves may be placed at the lobar, segmental, or subsegmental levels, dependent on the airway anatomy. Trapped air in the treated lobe escapes through the Zephyr valves until the lung volume of the treated lobe is reduced. The valves can be removed and replaced if needed. After treatment, the remaining lobes can expand more fully, and pressure on the diaphragm is relieved, improving breathing mechanics and overall lung function. Patients who respond to Zephyr valve treatment often experience meaningful improvement within 45 days.
I think that video is a great way to kind of see what these valves look like and see what we mean about these valves going into the lungs and how they help shrink the overinflated lung. And a little detail about the procedure itself. This is generally done under general anesthetic or conscious sedation. And I'm going to talk in a minute about collateral ventilation. And so I'm not going to go into details about that now, but we need to assess whether we think the valves are going to be effective before we place them. And that's a little what this assessment of collateral ventilation is. The procedure itself usually takes about 30 to 60 minutes. There's some reasons that we keep people in the hospital for 3 days, not in the intensive care unit, but on a regular bed. And I'll go into that in more details in a minute as well. And then individuals will follow up with their primary doctor for their regular ongoing emphysema and COPD management. But we also have some routine follow-up that we do after placing the valves. So I promised to talk about collateral ventilation, and we all have separate lobes of the lung. The right lung has 3 lobes. The left lung has 2 lobes. And in between those lobes is a fissure. It's a little like a crevasse on a mountain. It's a division between the upper lobe and lower lobe. But we all can be a little bit different in how complete that fissure is. Meaning in some individuals, the fissure's not very complete, and there's actually some air leakage that goes back and forth between the upper and lower lobes. In other individuals, that fissure is very complete, and air that goes into one of the lobes is not going to leak over into the other lobe. And this is what we call collateral ventilation. That is, if air is able to leak from the lower part of the lung up to the upper part of the lung, we call that collateral ventilation. It's air leaking from one lobe into the other. And if there's good separation between the two, then we say there's no collateral ventilation. The reason that's important is the way the valves work is by blocking the airflow into one of the lobes with the idea of trying to get that lobe to collapse down, to shrink. And that works if there's no collateral ventilation. What we have experience to show that really doesn't work if, even though we plug the main airways into that lobe, that there's still going to be leakage of air from the other part of the lung, and that part of the lung, the treated part of the lung, never shrinks. That just means we're going to have done a procedure that likely isn't going to be successful. So I'm actually going to go back one slide and say, this assessment that we do of collateral ventilation, we have a procedure that we do at the beginning to make sure that there's not this leakage of air between lobes before we place the valves. And sometimes we feel that we're not going to go ahead and place the valves because we don't think it's going to work. And that's important to evaluate with this Chartis procedure. So now I'm going to move to the results of bronchoscopic lung volume reduction, and there have been a number of trials. I'm just going to look at the top one, and there's a number of things that are important for all of us. You know, one is lung function. That's a measure that we do in the pulmonary function lab, and it's a nice number. But what really counts are things like exercise capacity and quality of life. But you can see that individuals treated with the Zephyr valve had an 18% improvement in the lung function. They were able to walk about 40 yards farther in a 6-minute walk. And that's a meaningful difference in terms of exercise capacity, kind of a standardized criteria of exercise capacity that we have. And there's also measures that are standardized for quality of life. And here, negative numbers are good. It means that things are better if there's negative numbers. So you can see all of these trials showed negative numbers that showed meaningful improvements in quality of life of the individuals that got the Zephyr valve. This looks at a whole bunch of different types of outcomes from any treatment that we would do for emphysema, things like lung function, the 6-minute walk test, and other parameters that we use to measure, are we making people better or not? And the blue bars are the patients treated with the Zephyr valve compared to the yellow bars that are patients not treated with the Zephyr valves. And you can see that by virtually all parameters, the majority of the individuals treated with the Zephyr valves had improvements. You can see that not everybody is improved, and there is variation in any one of these domains, but by and large, many more people are improved than by Zephyr valve that are not. But a key aspect is selecting the right patients. And what's most important probably for all of the patients is, how do I feel? What are my symptoms? And this is more of a subjective scale of looking at standard of care, somebody that is just being treated by their usual medical therapy and their symptoms, and an individuals that are treated with a Zephyr valve. And again, a negative number is good in terms of an improvement in emphysema symptoms over time. And you could see over a year that this got better and actually stayed better for a year. So the patient-reported benefits for the Zephyr valve are improved shortness of breath or breathlessness, dyspnea as we doctors call it, greater ability to do kind of normal activities, bathing, doing household chores, going for a walk, fewer limitations in many of the activities that people want to do, more energy, more confidence getting out of the house and doing things. So a general improvement in function, exercise capacity, and quality of life. And these are symptoms reported by patients compared to some of the numerical things that are important from a scientific aspect to make sure that when we're testing a new treatment like this, that we have true and meaningful benefit. I think important questions that I would hope all of you would have is, what are the problems? Is it safe? Are there any dangers of placing the valve? And one of the things that we've discovered is that some people can have air leakage from the lung and collapse of the whole lung, or pneumothorax, early after the valves are placed in about a quarter of patients. And in fact, it may even be a measure of how effective the valve is in a good way. But the pneumothorax is also something that needs to be treated. And that is the reason why, if you think back towards the beginning of this, I said we keep people in the hospital for 3 days. It's for this early stage of a potential pneumothorax, that we want people in the hospital where we can see if they're having any problem and we can take care of it. So that is a short-term risk of placing the valves. There are some longer-term aspects where people that have had the valves do better than people that have not had the valves in terms of COPD exacerbations or lung failure. And you can see that also in this graph on this side, that the people that have the valve have fewer episodes of COPD exacerbations and lung failure compared to standard of care, which means the medical management. So pneumothorax is a risk in the short term, but fortunately, the longer term risks favor having the valve. This is a slide specifically dedicated to what I was talking about in pneumothorax, or having air leak out and the lung collapse, and that the highest risk of that is in the first 3 days. That's exactly why we want people in the hospital under observation for 3 days, so we get past that time of highest risk where we can take care of it if it occurs before people are going home. So now I hope many of you want to know, how do I find out if I'm a good candidate? And patient selection is complicated. It's really important because in my practice, what I see is many patients with emphysema. We have multiple different things that we can offer them, valves being one of them. And the biggest aspect of success is picking the right patient for the right procedure and trying to make sure that we have the best chance of success by steering patients and individuals to the procedure that gives them the best potential for benefit. So there are a number of things that we do for screening in terms of evaluating the severity of emphysema, the degree of overinflation, that's what some of the numbers are there. Looking at a CT scan to confirm that there's emphysema of the lung and that there's not other major problems that would limit the potential benefit of a procedure. We then do a specialized kind of CT scan to look at those fissures in the lung. You remember I described to you that between the lobes of our lung, we have these fissures that are variable in different people. And those fissures need to be pretty complete to separate the collateral ventilation from one part of the lung leaking to another part of the lung. This CT scan gets evaluated in a specialized center, a laboratory, that gives us a report that looks like this, that tells us what does the lung look like and what do the fissures look like, as a screening tool to help evaluate whether somebody is a candidate for the Zephyr valve. Then when we go to doing the procedure, we take what we learned from this CT scan and we check to make sure that it really is true, because what we see on a CT scan is only an X-ray. It doesn't tell us what's really happening with the airflow in the lung and whether air is leaking from one part of the lung to the other. So we have this tool, the Chartis pulmonary assessment system, that we can actually block off airflow to one part of the lung and see, is air leaking from another part of the lung? So that's the last test we do before actually placing the valves, to make sure that we think the valves are going to work, that if we're going to place them, that there's going to be benefit. And then this is a picture from that video that I showed you, that then the next step, at the same time that we're doing that Chartis procedure, is we would place the valves. And the intent of the valves is to block off one whole lobe, because we want that lobe of the lung to collapse down and to shrink and to make more room for the other lobe or lobes on that side to have function and to work better. So I'm going to turn things over to Diane Lockhart, for many reasons. One is, she leads this at the University of Washington, and really, she and I work so closely together. She's a critical partner, and I lean on her a lot to help with the assessment of which patients should be considered for the valves or lung reduction or lung transplantation, or maybe aren't a candidate for any. And she's really the quarterback that keeps this working and is the real connection between patients and their pulmonologist and working with me. So Diane, let me turn it over to you and talk a little bit about the referral and the process of being evaluated for the Zephyr Endobronchial Valve.
Thank you, Dr. Wood. I'll talk to you a little bit about how you get a referral to our program. It's probably similar to many other programs, but the first question is, we have a comprehensive program for all patients that have emphysema or COPD. When they get referred to the University of Washington Medical Center, we generally evaluate for any of those procedures that Dr. Wood talked to you about, for Zephyr valves, lung volume reduction surgery, or transplant, regardless of why patients are referred. Our goal is to educate patients about what their options might be, as well as their referring provider and our team, so that everybody is on the same page. So a big question I get asked is, do I need a referral from my doctor to be seen at the University of Washington in our program? And the short answer is yes. And the reason for that is that we do want your practitioner, whoever it is that manages your COPD for you medically, to be supportive of your decision to seek advanced therapies like these, willing to work with you as we go through the evaluation process, and then also to resume medical management after a procedure is done. So generally the best way for them to do that is to just fax a referral directly to me. My name and my fax number are on there, but referrals get into us by many, many different directions, and they all seem to end up on my desk. When you get contacted, I'm going to be the person that you're talking to at the University of Washington. So if we can get the next slide there, what happens after we do get a referral, I review the records. Sometimes your doctor has sent them in to me, or we need to request additional records, or they're available through the electronic medical record system. I contact you by phone. We talk about the program. We answer questions. One of my primary objectives for my patients in this program is I want you to practice self-advocacy. So being your own manager and ask enough questions so that you can learn what you need to know to make informed decisions about these procedures, because these are all considered elective procedures. They are not procedures that we ever do urgently or emergently. They're not life-saving type of procedures, but they're to help improve your function. So they're very well thought out and carefully worked up procedures. When I look at your records, we are looking for specific diagnostic tests that help us make determinations about your eligibility. And if you've already had that testing done, then that's great. If we don't have it, then we coordinate it. We either get you in here to the University of Washington to have it done, or we work in your community to schedule it through your pulmonologist or your primary care doctor. We do get referrals from a very large geographic region. Here in the state of Washington, we service patients from Alaska, Idaho, Montana, Oregon, and Washington. So sometimes it's really hard for patients to travel here a lot, and we try to do as much in your local community as we can. Once we have all of the tests that we need, that give us sort of enough information to make preliminary determinations, then we review your case in our surgery committee. I present it to our surgeons, Dr. Wood, and then also Dr. Michael Mulligan, who is our other surgeon that does all of these procedures, and he is the surgical director of our lung transplant program as well. So we review those cases, and they make determinations, they make recommendations about what the next steps will be. So the next slide, please. This is unusual. I'm getting to tell Dr. Wood what to do right now, which is not normal. So the testing that we need for our initial review of your case are pulmonary function tests. If you have had emphysema for a while, then you know perfectly well what these are. We put you through a lot of different maneuvers to test different aspects of your lung function. An arterial blood gas, which is just a lab test where we take a syringe with a needle and put it into the artery in your wrist, withdraw a little bit of blood, and then that goes to a lab to analyze the oxygen and carbon dioxide content in your blood, gives us a very good idea about how your lungs are functioning. The chest CT scan, as Dr. Wood already mentioned, and then an echocardiogram, which is an ultrasound study of your heart, just to give us sort of a starter idea of how your heart is functioning, because the heart and lungs work very, very closely together. And when you do have a severe lung disease, it can often impact the function of the heart as well. All right, next slide. So after the committee reviews the case, any information, any recommendations that the doctors have made is put in a letter and it's sent to your referring provider. But before that letter goes out, I contact the patient directly and we go over it step by step, whatever that plan might be. If you are a potential candidate for Zephyr valves or lung volume reduction surgery, that generally involves being scheduled for some additional tests and a consultation at the University of Washington in our surgery clinic, where you would meet with one of the surgeons and myself, as well as our other staff, either our physician's assistants or our residents. Some of the things to know, important eligibility requirements for any of the procedures that we do here at the University of Washington. Keep in mind, you must be non-smoking. That has to be a habit that is put behind you. So patients that are currently smoking need to stop, or if they have only recently stopped, then we do screening. We require that you be non-smoking and not using any nicotine, tobacco, or marijuana products for at least 4 months before the evaluation. For patients who are maintained on oral steroids like prednisone, you have to be on a stable dose of 20 milligrams or less. Prednisone can interfere with healing after surgery in these types of procedures, so we want to keep it as low dose as possible. And then finally, as Dr. Wood also talked a little bit about the pulmonary rehabilitation, you have to participate in a pulmonary rehab program. This is a program of structured and medically monitored exercise and education for patients with severe lung disease. Our goal with pulmonary rehab, first of all, it has been widely studied for years. It is known to be one of the best known medical therapies for COPD, but we also want to try to maximize your fitness and what you're able to do, primarily walking, before you have these procedures, which is going to make a difference in your ability to recover afterwards. And my last slide, just a little bit of humor from one of my favorite comics, The Duplex. This is Eno and his dog Fang chatting, and Fang says, "How'd your doctor's appointment go, Eno?" Eno says, "He wants me to get more exercise. So I guess there's just one thing to do. Hand me the yellow pages, Fang. Looking for a gym? No, a new doctor." And I say, don't be like Eno, because pulmonary rehab is really important. So when we tell you you got to do it, that's what we want you to do. And I'm going to hand it back to Dr. Wood.
So let's talk just a little bit more about the patient benefits. And the benefits are an improvement in health status, improvement in quality of life and exercise, a feeling of less shortness of breath, and then the measure of less lung function and gas trapping. So some of these I emphasized from the studies. And this is another way to look at it in terms of shortness of breath, activity, psychosocial aspects of the improvement that people have after treatment. And I just do that as a prelude for introducing Ms. Angie Danaher, who's one of our patients. And we took this photo together just a couple of weeks ago because we wanted to have a photo of the three of us, but we were also trying to be socially distanced in this time of COVID. And so we're spreading out so we weren't too close to each other, but Ms. Danaher is there in the middle, and I want her to have a chance to tell you a little about what her experience has been as a patient, being cared for by Diane and myself, and going through the procedure of having a Zephyr valve. Ms. Danaher?
Okay. Hello,
Welcome
hello.
back.
Gosh, it's hard to know where to start, but I have to duplicate Dr. Wood's and Diane's commentary on the benefits of the pulmonary rehab. I can't state enough how much good that did me. When I was first being evaluated for lung volume reduction surgery, that was a prerequisite. And that was 3 years ago. And since then, I continued to work out even though I wasn't eligible for that surgery. And I'm now, since I've had the bronchial valves, I'm now walking like 5 miles a day. And at first, when I first started pulmonary rehab, I could not walk slow enough for the treadmill. I mean, the treadmill would not go slow enough for me to walk. And it was just a beautiful experience in terms of education and the monitoring, because when you're suffering shortness of breath with everything that you do less. The less you do, the less you're able to do, and it's frightening when you start having these palpitations and racing heart with medical monitoring there. It takes the fear out of it, and you learn how much oxygen you need to exercise beneficially. And I've gotten so much stronger. The quality of my life is so much better, even before the valves. But since the valves, it's increased exponentially. And I expect that to continue improving. So.
Angie, what are some of the things you've been able to do since the surgery that you weren't able to do before?
I mostly do everything I did before, but I do it much easier and a lot faster. And I'm doing a lot more because I'm looking around seeing all these things that haven't been being done because it was too much of a chore. And now everything seems to be easily handled, you know, so it's just making my life easier all around. I'm happier, more social. I feel like I have a fuller life, a new life. I anticipate each day now, rather than just getting through each day.
Wonderful. Dr. Wood, do you want to take some questions from the crowd?
I'm open for questions.
All right, so you had mentioned some comorbidities or that were disqualifying to people. What are some conditions that would make somebody no longer a candidate?
Yeah, well, the total list is large because obviously all of us can have other health conditions that may complicate whether we would benefit from a procedure or whether that procedure might have a lot of risks. The common ones are things like associated heart disease. Diane talked some about that, the reason for doing the echocardiogram, for example. Sometimes people with severe COPD get high blood pressure in their lungs, and that can be actually a serious problem if we then wanted to do either surgery or valves in that setting. That could be actually life-threatening. So we want to really study that ahead of time and make sure somebody with that problem is eliminated from a dangerous procedure for them. For others, it may be a lot of bronchitis. So frequent infections is another one of the more common reasons that might not be good to be placing valves or doing lung volume reduction surgery. On the other hand, you know, some people with really serious infections called bronchiectasis or cystic fibrosis, they can be treated with lung transplants and have those lungs removed and replaced. So there's many ways that we have to look at the total picture of the patient in determining, do they have risk factors that maybe make the procedure more risky or maybe less beneficial.
And are patients with alpha-1 antitrypsin deficiency candidates for this as well?
They are. And interestingly, there's kind of typical patterns for how people get emphysema. But of course, anytime there's things that are typical, there's lots of exceptions to that. People with emphysema after smoking more commonly have emphysema that's worse in the upper part of the lungs. And people with alpha-1 antitrypsin have the opposite in general, emphysema that's worse in the lower part of the lungs. But each of those can be treated with endobronchial valves.
Gotcha. Here's a question from Jim. I was unable to complete the 6-minute walk test or the pulmonary function test. Both were stopped due to my failure. I cannot read an MRI. Am I still a candidate for Zephyr? So can't do 6-minute walk, can't do a PFT. Am I still a candidate?
Diane, I'm going to throw that one to you.
You know, that's a really tough question. It's a very hard thing to evaluate people when we have very specific criteria in the breathing test and 6-minute walk test that have to be met in order to qualify. So usually we do have to find ways to get people through a 6-minute walk test and a breathing test. I have had patients out, you know, in remote areas where maybe they've tried breathing tests and they've stopped. But when we bring them here, I've got technicians that are so good and so supportive and encouraging that they've managed to get them through it. So I would not say that it's an absolute, but we do have to have some kind of numbers in order to know if you qualify or not.
Need some data. Why would somebody choose surgery over the valves?
Yeah, I'll answer that one. So there's some situations where people might not be good candidates for valves and would be candidates for surgery. And that gets into some technical details that are probably beyond our discussion here. Surgery has been tested longer. And I would argue that in the correct patients probably has opportunity for a greater benefit on average. The hard part is that there's a lot of variability and unpredictability of that variability in patients ahead of time, where some people I think that should have a lot of improvement with the valves have only modest improvement, and others have a huge improvement. And I've had the same variability in surgery. So we still consider that valves are a great new option for us for patients. Surgery is still a very good option for people. We saw 3 people today, and 2 of them that were new patients did not have the anatomy that was appropriate for surgery, but do have anatomy that's appropriate for valves. So yeah, the nice thing about having multiple options is we can look to see which options might be available for a given patient and offer them the treatment that gives them the best chance of improvement.
Thank you. And what about, so COPD and emphysema are both obstructive diseases. Is there any value in this in restrictive diseases like pulmonary fibrosis?
Short answer, no.
Gotcha. So don't even make the phone call. I also wanted to mention that if your doctor is interested in finding out more information, you can contact Pulmonx and they will contact your doctor for you. Quick question, will these valves cause a problem with an MRI?
No.
Will they cause a problem at airport security?
No. We all look forward to being able to go through airport security again, but fortunately they do not have an impact on airport security either.
Do you more often place the valves in both lungs or one at a time?
Yeah, that's a really good question because surgery is typically treated both lungs, which is one of the reasons, one of the things that's developed with surgery and part of its effectiveness. We've learned with the valves, because they treat a whole lobe and surgery does not, that the preference is to treat one side. So we treat one side with the valves, so usually one lobe. Occasionally on the right side, we might treat 2 lobes because the middle lobe that sits between the upper and lower lobe is a small lobe that sometimes it works better to fit with the upper or lower lobe together.
Gotcha. And is there an age limit for this procedure?
No.
What's the youngest and the oldest patients you've done in your hospital?
Diane.
That's a very good question. I I'm not sure. It's generally probably in the upper 40s up all the way to, we've done 80-year-olds. Now, lung transplant, they don't transplant after the age of 70 at our program, but for the others, it's more of a matter of overall health and function. So,
And actually, youngest, going way back, we've had a patient in their 30s for lung volume reduction surgery. But most people with emphysema, except for those with alpha-1, they're older. So they're usually 50s, 60s, 70s. And we do have some 80-year-olds that we've treated as well.
Gotcha. On an average week or month, how many do you personally do?
So these type of patients, we're probably evaluating about 12 to 15 per month in terms of overall evaluations. In terms of procedures, we're probably doing about 3 or 4 per month.
Okay. And is there kind of a standard wait time from like once you make, specific first contact to how long it takes to get the valves done?
Well, there are several layers embedded from first contact because if you remember what Diane talked about, there's some important information to gather and testing to accomplish. And that takes different time depending on how responsive the local system is in getting tests done, whether you're in Anchorage or Missoula. But I'm going to jump forward and say all the tests are done and you're a candidate. Is there some queue for having the procedure? And the answer is we need to make sure that your insurance company is willing to pay for it so that you're not saddled with that bill. But except for that, the scheduling is pretty straightforward and we would do somebody within the next 2 or 3 weeks.
Gotcha. So I have a couple of conditions I'd like to ask you about, whether or not these are disqualifiers in any way. Pacemaker?
No.
CHF?
Potentially. So that depends on the severity of the congestive heart failure. So this reverts back to your earlier question about other health conditions that may
Right.
problems. And I mean, some people have congestive heart failure that is well managed and is stable and is not immediately life-threatening. Those patients could still be considered for endobronchial valve. Some patients may have a deteriorating course or be unstable or have a very short life expectancy because of the severity of their congestive heart failure. And it's probably not appropriate to be doing another procedure and adding some additional risk for them if they have that disease that's that severe.
Thank you. And Angie, here's one for you. Before this procedure, were you on oxygen?
Yes, I've been on oxygen from my first diagnosis, pretty much 24/7.
And how much oxygen were you using on a typical day for rest and activity?
2 liters. And now I've been able to cut it down to a 1.5 for the most part. I don't have to have it if I'm just sitting around. But when I'm exercising, I do between 2 and 3, which is an improvement also. I used to have 3 or 4. So
Awesome.
that's good.
What device do you use?
What device?
What oxygen delivery device? Do you have like a portable concentrator, or do you take tanks, or?
I've got, actually, it's quite a good setup. I've got little tanks that I can fill from my big concentrator, and they're pretty portable, so I can take them outside. I don't have to be dragging something along with me. And I can carry them in a backpack if I want to, do my shopping or whatever, and it's pretty convenient. But I would love to not be saddled with oxygen tanks for the rest of my life. That's
Sure. Well, if you bump up from your five miles per day to 10 miles per day, that would probably move you in that direction. So
Hey, I'll be jogging if I can do that.
okay.
Yeah, I want to point out how impressed I am with the 5 miles per day. I mean,
Just
I don't do 5 miles per day.
Well, it
Yeah,
takes me forever, Dr. Wood.
Well,
I've got all the time in the world, you know.
Ms. Danaher, you impressed me. You know, the 5 miles a day, when you told me that in clinic, I went, holy cow.
Yes.
That's great.
Oh, I've met all the little kids in the neighborhood since I can't go to the gym anymore. You know, it's been kind of fun, actually.
Forget even the physical, just the discipline to get out on the road every day. Good for you. Can we talk a little bit about, you know, Medicare versus private insurance coverage and what that's like?
For
Diane?
me or Diane? Diane?
Yeah, let's do that with Diane.
Diane, Angie wants you to
You know,
take that one.
Medicare paid for mine, but
That's okay. So yes, as far as insurance goes, because these are relatively new, the endobronchial valves, not all of the insurers, they drag their feet a little bit. They're a little slow to get with the program. And so there are many of the big ones that have not yet updated their coverage policies. And endobronchial valves are still listed as experimental. And so when Medicare is not that way. They have not made a universal coverage decision yet, but they are paying for it. So on an individual basis, we've not had any issues with Medicare payments. For those insurers, there are some insurances that have updated their policies and they're covering this. For the ones that do not, when we first submit to get authorization for the procedure, if we get a denial, the Pulmonx company has a great team. I'm actually glad this came up because we've had to work with them a couple of times. They have a team that is the patient reimbursement team. So they will pick it up from there and they work on all of the appeals. And we had a case recently that went through 2 appeals and then an external review, which means that somebody not associated with the insurance company did a review, an independent review of it, and overturned the insurance company's decision. So that person is in fact on our schedule to have this procedure a week from this coming Monday. So that's a great thing. So the Pulmonx patient reimbursement support team they do a very good job. And I think that the more that we do this, those insurers are eventually going to step up and make the changes so that we don't have to go through that. So.
And of the patients that you do evaluate, what percentage would you say don't make it, like as far as like are not candidates?
Well, I would just say that from all the referrals that come across my desk, when it was just lung volume reduction, so probably 1 out of every 10 would finally get to surgery. Some of those that went on, some of those went on to get lung transplant. Because they just didn't qualify for lung reduction. Some of them don't qualify for anything. But I think since we have added the valves, I think that number has gone up. I really do. I think that probably more like 2 to 3 out of every 10 patients might end up qualifying for something. So.
And I guess the better screened they are by their home physicians, the better that chance is as well, right?
Yes.
Yeah, I'll just add, the point that you made is, in one sense, we don't want the referring physicians to screen too much because I also find that sometimes they inappropriately screen people out. We're happy to talk with referring physicians, to review the data with them and to help evaluate what options there might be. It's okay for us to screen more people to make sure that we're not missing anybody that might be candidates.
Absolutely.
That's great to know. Okay. Is a past lobectomy a disqualifier?
Yes.
Okay. Angie, somebody wants to know, are you doing your 5 miles on the road or on the treadmill?
I've been walking in my neighborhood. I don't have a treadmill. I did use a treadmill at the gym, but since COVID, I haven't been able to do the gym. So it's just in my own neighborhood, which is fairly flat, only a couple small rises that are still kind of killer elevation-wise for me. But I do them anyway.
Got you. If you've had lung volume, this is not an option. Medicare does cover. You said 2 folks out of the 3 today could not be candidates because of their anatomy. What is meant by that, or what did you mean by that?
Yeah, they were not candidates for lung volume reduction surgery, which requires quite a specific anatomy of what we call heterogeneous upper lobe predominant emphysema, which means that the emphysema is much worse in the upper lung zones and less severe in the lower lung zones, so that we have what we label as a target area for removal. That's like that diagram that I showed about where we remove part of the lung. And we do some special scans to help me see where the lung function is. And on both of those patients, I could see that the lung function was fairly evenly distributed throughout the upper part of the lung and the lower part of the lung. And that really is not good for lung volume reduction surgery, but it's not a contraindication or reason that we cannot do valves. So those patients, we're finishing the process of evaluating for the Zephyr Endobronchial Valves.
Got you. How often does Chartis suggest no collateral ventilation, but then once you get inside, you do find collateral ventilation?
So I'm just going to work on the semantics here. The Chartis is the final assessment of the collateral ventilation. The first part is called StratX, which is with the CT scan. And in my experience, the StratX is good, meaning it's a very good screening tool that most of the time will find a similar result with Chartis that is the actual assessment. But we have had some patients where when we then test it during the procedure, we can see that in spite of the favorable x-ray, that there's too much collateral ventilation. Yeah, it's hard for me to put a percentage on it, but I guess I'd say it's maybe 20 or 25% might not make it to valves if they get to that point.
And is there a weight restriction, either high or low? How does that impact the valves?
Diane?
Yes, there's a recommended. They have recommended that the body mass index, which is a factor of your height and weight together, that it not be over 35. That's the max.
So, final thoughts, Dr. Wood. What's your final sentence or final piece of advice you'd like to give to people before we go?
Well, yeah, thanks, Noah. I want to thank especially Ms. Angie Danaher for joining us and being willing to put herself out there, tell us about her experience. She's brave to do that, and she's inspiring also to see what she's doing and how she clawed back from being able to barely walk on the treadmill to walking 5 miles a day around her neighborhood. That's really impressive. And thank you for sharing your version of the story. And I also want to
thank you for inviting me. I appreciate.
It's good to have you. It's good to join in this together. And I want to thank Diane. I need to thank Diane for so much, because she and I have been like this for 22 years working together with emphysema patients that needed lung volume reduction through a trial, now through all of the valve trials, and now being able to do valves. So she's the brains, I'm the technician.
Absolutely. I've really appreciated Diane too. She's been so helpful and informative. She's called me when she's been on her way to vacation. I just love her to pieces, and I really appreciate all her help and encouragement over the years.
I love her to pieces too.
I bet you do.
Well, the thing I'll say about the presentation is there are options for people with emphysema, and those options aren't going to work for everyone, but there are options that are interventions.
Mm-hmm.
We have surgical options. I described what they are. Those are still legitimate and important options. And the nice thing is we've got this newer option of an endobronchial valve that is minimally invasive, has a low risk profile, and can achieve benefits like one sees in Ms. Danaher with less risk or process than there is in going through a major surgery. So this is as much as we don't want anyone to have emphysema, the nice thing is we have now additional therapies, additional options for people with emphysema to hopefully make their function and quality of life better.
Yeah,
Thankfully.
I concur. I mean, this is the most exciting thing to happen to emphysema since I've been in practice. I love it. I've had a number of patients who their lives have been dramatically improved. Diane, final thoughts?
Yeah, no, one thing I think Angie brought up a minute ago, sort of that elephant in the room, the COVID. She mentioned the C word. And I just want to emphasize the fact that at the beginning of the pandemic, our program was shut down. A lot of patients had their workups, their procedures and everything put on hold. We resumed working up patients doing diagnostic testing in May and started doing the procedures again the first part of June. And we continue to do it. And so I want people to know that despite this ongoing issue with the virus and all, we are still evaluating patients. We're taking special precautions prior to doing breathing tests or being admitted to the hospital, having the procedure. We are doing COVID testing. We've not had any patients, honestly, in my whole practice, I don't know any patients with COPD that have come down with COVID. So this is a good thing. We're being super cautious, I think. So I want people to be aware of that.
Our community heeded the warnings. They took them seriously. So big up for that. Angie, final thoughts?
I'm just very thankful for the valves. It has just given me a new lease on life. I can't wait to see how much better I improve over the months. And, I'm looking forward to road trips and going places that I haven't been able to go because the elevation is too high for me to function well, no matter how much oxygen I take with me. And I'm just, it's just given me an appreciation for life in general. I can't wait to be able to run with my grandson, and it's just, life is beautiful.
Super inspiring. Let me know when and where. I have a convertible. And just one more question. Does having COVID and recovering from COVID eliminate you from this in any way? No.
Once
Okay.
recovered from COVID, one would still be a candidate for the procedure.
Wonderful. Ladies and gentlemen, thank you for tuning in. Dr. Wood, thank you so much for being here. Diane, thank you so much for being here. Angie, thank you so much for being here. And with that, we bid you good evening, everybody. Have a great night.
Thank you.
Bye-bye. Thank you.
Good night.
See you soon.